Welcome to the Ocular Surface Academy podcast, TFOS DEWS 2 edition. Join us as we meet with the researchers behind this landmark international consensus. Each episode will feature practical clinical takeaways. Before we get to today's episode, here's a quick word from our sponsor.
At CALA, we know that very often eye diseases aren't just painful. They can be life-limiting for patients. Because diseases like dry eye can have severe physical and emotional consequences. So we committed to helping these patients. We assembled an unmatched team of eye care professionals. We pioneered a whole new technology for ocular medicine. We developed and launched the first BID steroid for postoperative pain and inflammation following ocular surgery. And we are now launching the first and only prescription therapy specifically designed to address the short-term treatment needs for people living with dry eye disease. We are CALA Pharmaceuticals, and we are committed to advancing the treatment of eye diseases. We are creating our own treatment, and now we're at the beginning of the next chapter in our exciting journey together.
Welcome your host and co-host for today's episode of the Ocular Surface Academy podcast, Dr. Scott Schachter and Dr. Christopher Starr.
So welcome everybody to Ocular Surface Academy, going through the TFOS DEWS 2, Turning Research into Reality, joined as always by Chris Starr in New York, the star ophthalmologist of New York. And today we have Christophe Baudouin, the internationally recognized Christophe Baudouin, who I'm personally a big fan of all his work. Christophe, you've been a professor since 1995, is that right?
Exactly.
I was reading about, through your bio, you are currently president of the newly created European Dry Eye Society. How long has that been around?
We launched the society 1 year ago, and most of the experts in Europe belong to this society, and they were also part of the TFOS Dry Workshop. It's a pleasure to have a combination of European specialists.
Very good. And you, how long have you been editor at French Journal of Ophthalmology?
The French Journal of Ophthalmology, so plenty of years, 20 years.
All right, that's essentially your publication, it sounds like. That's great. And you know, most of you were awarded Silver Fellow at ARVO in 2011. Congrats on that. That's a great honor. And you have published more than 450 papers. And you know, at some, I hope to get you back on another time to talk to you more about your very well-known vicious circles, which I can tell you, what year did that get published?
The vicious circle initially was published in 2007, but then it improves and it was adopted by in the journal The Ocular Surface in a review we have published in 2013 to try to really emphasize on the fact that dry is really a disease where a cascade of the biological events self-stimulated and bring the patient to a condition where it's very, very difficult to escape because the cause may be disconnected from the consequences.
Well, I'll tell you, amongst my colleagues who do a lot of speaking around the country and the world about dry eye, vicious circles is probably the number one term that I ever hear. I hear about vicious circles all the time, rightfully so. Really great paper, well done. You've also done a lot of research on inflammation, dry biomarkers, which hopefully we can touch on today. And then in particular, glaucoma medications and preservatives, which, you know, for ocular surface doctors it's always a real quandary. Sometimes we treat one disease and create another at the same time. And so I'd love to get your insights on that. So we'll jump in, and we're really going to cover about 4 topics that the Iatrogenic committee talked about, and in particular surgery, contact lenses, cosmetics, and then medications, both topical and systemic, things that we all see in our practices every day. So Chris Starr, why don't you kick us off? And you know, Chris created, again, this ASCRS algorithm for preoperative evaluation of patients prior to refractive and cataract surgery. And tell us a little bit, Chris, what questions do you have for Professor Baudouin about the surgery in the committee?
Well, yeah, I think most of us recognize these days, and certainly in the Iatrogenic Committee of TFOS DEWS II, surgery was a culprit when it comes to inducing iatrogenic dry eyes. Laser vision correction certainly being one, LASIK, and but really any incisional surgery, whether it's retinal, glaucoma, corneal transplant, cataract surgery even, can affect the corneal nerves and induce a form of dry eye or ocular surface dysfunction after surgery for a period of time. And in the context and the sort of motivation for Ascaris, and I was the lead on this algorithm that we created, the idea was really to identify dry eyes prior to surgery because of the impact that ocular surface disease and dry eyes can have on IOL calculations, on refractive outcomes, patient satisfaction. And then, of course, there's the component of worsening after surgery, worsening vision. And also, if you throw in other ocular surface diseases that involve infectious etiologies, like anterior blepharitis from, say, bacteria, then you also potentially are increasing the risk of endophthalmitis or another postoperative infection. So that was the impetus for the Ascaris algorithm. And a lot of that was the Ascaris algorithm wouldn't exist without the TFOS DEWS II and your subcommittee that talked about iatrogenic dry eyes. So I'll hand it over to you, Christophe. I'm just curious. I know the committees are diverse, and sometimes this, especially the surgical aspect of dry eyes and laser vision correction in particular, can sometimes be a bit controversial. If you look at the data in the literature, it's all over the place, from less than 1% to 100% of post laser vision correction LASIK dry eyes. So how did the committee approach this, and was it controversial in any way? Was there back and forth? I wasn't in the room, so we'll ask you.
Thank you very much. You addressed very important question. Regarding refractive surgery, effectively, it has become the major complication of refractive surgery. Unsatisfactory patient, complaining a lot of dry eye, putting eye drops, suffering, burning sensation, and maybe even more important, the visual aspect of dry is very important. If you have a wonderful surgery for cataract surgery with a premium IOL, but the patient is suffering from halos, from blurred vision, from diffuse scattering, and ocular fatigue, and difficulty in accommodation, of course the patient will be unhappy. And you may have a wonderful 20/20 vision surgery, but the patient would be extremely unsatisfactory. Effectively, we can discuss about the frequency between it's constant and it's very rare. It seems serious to consider that 15-20% of the patient have more or less some problem, whatever the surgery. So it's not huge, but it's important. Regarding refractive surgery, of course, the nerve transection play a major role. It's clear. And we can observe that with confocal microscopy, observing abnormalities of the shape of the nerves, of tortuosity, hyperreflectivity, and inflammatory cells. And probably inflammation is a major component, whatever the technique. Besides that, it's clear, and you mentioned that, and I'm 100% with you on the fact that probably the most important risk factor is not surgery itself or any issue with surgical procedure, but it's what was before surgery. The risk factor is the condition before surgery. If a patient has a dry, and for refractive surgery, we have a good example of patient wearing contact lens, stopping wearing contact lens due to dry, progressive dry, probably due to inflammation and impact of the lens on the tear film, or maybe external condition, the patient will be at higher risk to develop postoperative dry. So prevention is identification of the patient, information of the patient, treatment of the patient whenever possible, and sometimes proposing the patient to postpone the surgery, or even proposing the patient not to do surgery at some moment, maybe later on. But it's better than having a very, very unsatisfactory patient. So prevention before is very important. A last point, The problem is that sometimes patients are not so symptomatic. I have seen many times elderly patients before cataract surgery with very bad condition at the eyelid margin, with inflammation, with crust, with redness. By definition, it's a MGD. But asking them, do you suffer? Do you have symptoms of that? No, sometimes 2 times. But those patients after surgery may complain a lot. And we have always seen patients after cataract surgery, a perfect cataract procedure, and suffering of the eye that was operated. Oh, you have dry? No, it's not. I don't have dry on both eyes. I'm suffering since the surgery on the operated eye. Unfortunately, it was just because it was dry before, inflammatory before, and the patient moved to a more severe condition.
You know, on a side point there, you bring up something that's been on my mind quite a bit of late as Tarsus develops a medication to treat blepharitis, in particular for demodectic blepharitis. Why don't those patients complain? Why can I see a patient with all kinds of crusting on their lashes, their eyes might be red, their OSDI might be 4 or 5, a very low number, their speed scores are low, they have no complaints. And I look at this eye and I think, you look terrible. Why aren't patients with blepharitis complaining more? Do either of you have insights into that?
Maybe I can start because I don't have the answer. To me, it's really a mystery. We have seen many patients with mild to severe blepharitis, and complaining a lot, coming back to our office. Oh, it's unbearable. I'm suffering. Do something for me. And some patient with apparently similar condition, but complaining just a little or sometimes not at all. Is it just psychology of the patient? Maybe. Is it due to other confounding factor we are unable to discriminate? Maybe Demodex, maybe a higher rate of staphylococci or microorganism contaminating the eyelid, which means that, as effectively it was told by Chris, effectively the risk of further infection is higher. I don't know exactly, but there is something occurring at that level, maybe at the level of the nerve that are more or less stimulated. So it's really a mystery to explain why there is such a discrepancy between similar sign and totally different complaint of some of the patients.
Yeah, I wonder if the nerves that innervate the lids, in the same way we see neurotrophic keratitis, we've got patients with corneas that look awful and they're not complaining. Maybe their vision's a little bit blurry. And it makes me wonder if there's nerve damage occurring at the level of the lids where you've got this infestation and maybe their lids have lost some sensitivity. And you mentioned
you've heard it here first, a neurotrophic lid disorder, the Schachter neurotrophic lids.
Well, what do you see similar in your practice?
I would love to say that patients never complain with blepharitis, but on the Upper East Side of Manhattan, they do. But you're right, I'm being facetious. Certainly, we've looked at studies in pre-cataract surgery where we've looked at objective signs and comparing those to symptoms in blepharitis, but also dry eyes. And we've looked at osmolarity and MMP9. And Priya Gupta and I published a study on this in JCRS a couple of years ago. And we found that certainly in these patients who are prior to cataract surgery, generally an older patient population, those patients, about 80% of them had at least one abnormality of osmolarity or MMP9. About 50% of them in the asymptomatic group who had, we used the Sandy questionnaire mostly, and then on those patients who had a 0 Sandy, about 50% of them had abnormal osmolarity and MMP9. So it goes to show you that there is a disconnect between signs and symptoms, which everybody is well aware of. And the question is why? And of course, in a lot of these older patients, there is a neurotrophic component with age. Some patients, it's like Christophe said, it's psychological differences amongst patients, and some are complainers, some aren't. In the cataract patient who has a visually significant cataract, often patients there will be a hierarchical component to their complaints, and often patients feel like they only have one complaint to make. And in the case of a cataract, it's the cataract and not the dry eye disease and ocular surface. So there is a big disconnect. There are a whole bunch of reasons for it. But getting back to the ASCRS algorithm and Christophe's work, and what Christophe said, identifying it prior to surgery is so important. And this is why with the ASCRS algorithm, signs were much more important in the preoperative patient than, say, symptoms. If you're using a symptom questionnaire purely to screen these patients, you're going to miss them. A lot of them are asymptomatic. But the signs, we have corneal staining, rapid tear breakup, osmolarity, MMP9, were highlighted in our algorithm because of the potential visual significance of those signs. There are studies that look at osmolarity having an impact on IOLs, hyperosmolarity, similarly inflammation and the vicious circle, as you mentioned, Christophe, and published, which will get worse, if you do surgery and put a lot of toxic medications on the eyes. So it's important to identify this pre-op to avoid complications, perceived complications or real complications by the patients postoperatively.
Other than preparing the ocular surface and screening for dry eye and ocular surface disease prior to surgery, and other than going from a microkeratome to femtosecond laser and trying to be less invasive, what major innovations have occurred over the years in LASIK and cataract surgery to reduce the postoperative complaints and dry eye?
Regarding LASIK, what seems to be technically an improvement is a technique that was developed and that is available in Europe, is a SMILE, the small incision LASIK surgery. It's similar to LASIK, a little bit different in terms of flap management. And we have done a work showing that there was a decrease in frequency and severity of dry eye after compared to LASIK. So if technically available, this can be a good option. But we know that sometimes it's a little bit tricky to make the technique. So this is an option. Regarding cataract surgery, of course, the role of the incision, so micro-incision around 2 millimeters, is a way to reduce the risk of developing further nerve damage. The light in the microscope seems also important to consider. There is a phototraumatism to the surface. I'm not sure it's really a major difference compared to what we were been doing a few years ago. That was not so different. And I'm not sure it will decrease the risk of developing dry. Anyway, I would also put forward some mistakes, some common mistake. We are probably treating too much after surgery, too much steroid, too much non-steroid agent, too much antibiotics. So reducing the number of medication, maybe not stopping everything, of course, but reducing the number of medication and duration of treatment is also a good option. Just one short point. We have seen extremely severe corneal complication in patients developing corneal ulceration and probably too much treated with antibiotics and especially NSAID. That may become toxic, and we have seen corneal melting after any kind of surgery. So it's very important to inform the ophthalmologist to stop NSAID whenever the cornea seems to suffer a lot and not to recover properly with ulceration and, of course, ulcer and something even more severe.
Yeah, those are great points. I'm curious about we do have SMILE in the United States now. It was fairly recently approved. It's not, certainly not as popular as, or widely available as, say, LASIK or PRK, but it's growing. And the studies that I looked at when it first came to the U.S. As far as dry eye goes and corneal sensation postoperatively, the literature seemed a bit mixed as far as was there an advantage or not compared to LASIK or PRK. And I'm just curious about the study that you just mentioned that you did looking at SMILE versus those. What were your metrics and outcomes in that study?
We had two metrics. One was the vision, the optical aberration. And we have a system that is able to measure the scattering index that is used for measuring the modification of the cornea transparency or the lens transparency. But this technique has the advantage to also measure the variation of the scattering index. And this variation is due to the lacrimal film, which relates abnormal tear film with visual consequences. So this is an interesting approach that is also available for any kind of dry. And effectively, there was a reduction in the variation and the aberration driven by the abnormal tear film. So this is an objective metrics. Also, we observed that the patient at 3 months and 6 months were using less tear substitute, have a lower rate of corneal staining. So it was a significant difference. But to be fully honest, it did not prevent totally dry development and aggravation of a pre-existing dry. So it's an improvement, not more, unfortunately, not a definitive modification.
Yeah, so surgery, in iatrogenic, for the doctors who may not be familiar, we're talking essentially about the things we do to ourselves that cause dry eye, treatment cause versus, commission of treatments versus omission of treatments. And, with surgery, preoperative assessment, right? That's where you came in, Chris, and your algorithm for preoperative evaluation and just talking about surgery in general. We're not just talking about cataract and refractive surgery, but we're also talking about cosmetic procedures, for example. Blepharoplasty can be another. And one thing I've come to find of late in doing some research on neurotrophic keratitis is that pars plana vitrectomy is another one that can cause a loss of sensitivity of the cornea. And that was sort of news to me. And I've recently identified in some patients of mine who've had vitrectomy that they are actually neurotrophic. So the nerves seem to be playing a very big role. And do you think in cataract surgery, so cataract surgery versus LASIK, you're cutting a lot less nerves, correct? In cataract surgery?
Only very few, effectively.
So do you think that there's more to it than the physical damage to the nerve, that in terms of how the surgery is performed, how long the eye is exposed, what you're using during surgery? Do you think that plays much of a role?
Certainly, it is one of the hypotheses about the development of dry after cataract surgery. To be honest, I am not fully sure that cutting a very small section of the nerve in the higher part of the cornea, the limbus, would be so much important for the development of the neurotrophic or neurotrophic-like keratopathy. It's probably one element together with the addition and probably more the accumulation of drug in already sensitive corneal surface would be, in my opinion, more important in that case. In refractive surgery, no doubt that the nerves play a role. In cataract, I'm not so sure. Regarding just one point, you mentioned cosmetic surgery like blepharoplasty. In that case, probably the blinking rate and the quality of the blink is probably an important point, because sometimes we observe, and I've been observing dry after this kind of surgery, in which the patient was totally able to voluntarily close the eye, but when observing the spontaneous blinking, it was in many cases an incomplete blink, and I would encourage our colleagues to observe the patient during the first part of the examination, just discussing with the patient, describing the symptoms. And sometimes you observe that when the patient blinks, a part of the eye is still open, and in that case, it's due to incomplete blinking, and it's especially typical of this kind of surgery, but it can be spontaneous anyway. So, and those patients are able to completely blink if you ask them to blink, but spontaneously the blinking is incomplete. So, of course, a part of the eye is exposed to the environment, and this may cause an important component in dry, if not the major component.
And for the optometrists watching today or listening today, I personally steer a lot of my patients away from general plastics for that sort of procedure, either to ophthalmologists who I know is very skilled at the procedure, or oculoplastics, who I think are going to be more tuned in to the function versus just physical appearance of the blink process and the lids. Chris, I'm curious about your opinion on something like that. And I know this may be a little controversial. plastics may not like ophthalmologists or oculoplastics, the scope of what they do. But do you find that sort of a thing? Is that the consensus in the ophthalmology world for either of you?
Well, I mean, I think certainly plastic surgeons who do a lot of blepharoplasty are certainly aware of the potential effect on dry eyes and exacerbation of dry eyes, which is why we often will see patients in consultation prior to any of those surgeries, and they still often request Schirmer test, which, as a measure of tear production. That's a test that we don't do very often routinely anymore, but certainly when the plastic surgeons send patients, we do it for them. So they're aware of it. And if a patient has a significant dry eye or, a wetting of 0 on the Schirmer or a ridiculously high osmolarity or whatever, other ocular surface dysfunction there is, we'll often, report back to the cosmetic surgeon. Now, maybe let us treat this first. We'll see if we can get this under control, improve the tear production, and then, maybe do the surgery if we can get it reversed. But if not, this patient is not a good candidate for this. And we'll discuss that with the patient. But the patients seem to be pretty knowledgeable about it. And plastic surgeons, for the most part, are as well. Did I answer your question? I'm not sure I answered the question, but
yeah, I think you did. I mean, I think it's probably very just physician dependent. Some plastic surgeons will be tuned into it, some may not. Same for ophthalmologists, probably. Some general ophthalmologists some are going to be more skilled than others, clearly, right? Because I see a fair amount of, if you're doing too many surgeries, then you're really kind of pulling back, and you're probably going to be at risk. And Christophe, what's the general protocol in Europe for blepharoplasty? Who performs most of those procedures there?
Either a plastic surgeon or ophthalmologist. And it's not really a joke, but a little bit. After this kind of surgery, you observe very easily who performed the surgery. I don't do that personally. But when you have a quite perfect eye, it's plastic surgeon, but sometimes the eye has some difficulties in blinking, in closing the eye. And an ophthalmologist will be more aware of the natural aspect of the eye, of the eyelid, and the blinking. So if you still observe wrinkles or something like that, you may expect that it was done by an ophthalmologist. But it may depend on the expectation of the patient, of course. Some patients want to be absolutely perfect, but they take a risk. And if they had already dry before this kind of surgery, it may be really, really risky to make it, where sometimes very, very poor consequences with corneal ulceration and sometimes very, very bad condition.
Yeah, in surgery, it sounds like in general, the key takeaway is the prep work. It's the preoperative analysis for any sort of surgical procedure, in addition to close monitoring, probably post-procedurally, to make sure that the nerves are functioning well, hopefully, or they're recovering, patients are recovering. And so moving on to contact lenses briefly, contact lens dropout rates unchanged in the last 20 years. And I always talk about it this way. Personally, I always used to be a brand chaser and modality chaser versus, I've switched of late to fix the eye first approach. And then I think most patients do well with contact lenses as long as you fix the eye first, similar with surgery. What were the findings of the subcommittee in terms of contact lenses? Effectively,
it's common to observe what we can call dry related to contact lens. However, it's not so clear. It's not so clear whether or not the contact lens by itself will cause a dry, or if it's not more often related to the solution for cleansing the contact lens, or if it is not sometimes due to misuse of contact lens. For example, keeping the same lens for the night, or keeping the same lens for a long period of time, or not cleaning it properly or disinfecting it properly. So it's not so clear. When you observe patients with no symptom, a long-term contact lens, you can biologically observe some modification, but in fact, it seems not to be pathological. It's just a borderline of the normal physiology or abnormal physiology, but on the border. Otherwise, they can move to condition that is fully pathological, and effectively develop a drug that will result in stopping wearing contact lens. More important than the material itself, I would say.
Yeah, it seemed like daily contact lenses that fit a little bit tighter were part of the solution. And you're talking about contact lens induced dry eye versus contact lens associated dry eye. And always struck me when I came across our paper that said the average onset of dry eye disease in a contact lens wearer is 27 years old. That's pretty telling. So careful assessment prior to contact lens evaluations. And the industry has done a great job of giving us better materials and designs and solutions. So contacts, fix the eye first. That's always been my mantra. And I want to go ahead into cosmetics now. We know in the United States, the last time we updated our legislation regarding cosmetics, Franklin Delano Roosevelt actually signed that into action in the 1930s, I believe. Europe updated their contact lenses or their cosmetic ingredients list in 2008. Did you play any role in that, or what was the culture or environment in Europe that brought that to fruition?
Oh, it's a very interesting and very difficult topic right now, because Europe has forbidden the use of animals to test any cosmetics, which means that, in fact, you have in vitro pre-screening of cosmetics. You have well-known irritants or allergenic compounds that have been more or less eliminated, because the cosmetics contain between 30 and 100 different components. So even the hypoallergenic, so-called hypoallergenic cosmetics still contain a lot of different compounds. But what is a little bit funny that as the animals have been eliminating from the pre-screening before going to the humans, in fact, the first animals to test a new cosmetic is precisely the humans. So sometimes the discovery of any new tricky condition can be observed in humans. So I would say that effectively there is a strategy, a movement to the elimination of the most toxic and the most allergenic compounds. But there are still many components that are given for different purposes, disinfection, prevention of oxidation of the compounds. So it's diffusion of the makeup or the compound. So it's still a little bit tricky. And I would say that it's important again to discriminate cosmetics in fully normal young people and cosmetics in elderly patients, postmenopausal women who start to develop progressively some dry or dry-like condition or sensitivity, and who will develop progressively even worse condition. This is a topic we can also discuss about the medication. There is a way to understand that is in fact wrong. We are used to consider that if a component was well tolerated for 1 month, 1 year, 2 years, normally it's proves that there is no influence on the ocular surface, no intolerance. But in fact, intolerance may develop progressively, especially with the slightly toxic compound. The highly toxic compound are eliminated immediately. But the slightly toxic, irritating compounds will progressively develop toxicity, and this may cause consequences that will be visible after a few months or even few years of use. In that case, you well understand that it's very difficult to relate a dry, to relate irritation, an allergic condition or blepharitis to what was started 2 years, several years before. And this is very difficult.
Is that what you're seeing, Chris, too? I mean, I know you've got involved a little bit. We spoke to David Sullivan recently, and I know he's done some work looking at the effects of different preservatives on meibomian glands, for example. And when we see patients in practice, every single day I'll see women with mascara that's floating in the tear film. We'll see concealer, I believe it's called, that migrates over on top of meibomian glands and is floating in the tear film. That's really interesting that you say, for all that Europe has done to remove about 1,000 or more, maybe it's 1,400 potential or ingredients that are allowed in cosmetics. And the US, I think, has a list of about 12 to 15. You can see that and as eye doctors in the US, it's not something we're all necessarily comfortable talking to women about their cosmetics. Chris and I have spoke about this before. We are not that tuned in to everything that women do to make themselves look like they do every day. And they go through many, many different things, mascara and concealer and eyeliner amongst some of them. So these really do interact with the eye. They become part of the body. I think there was recently some case that was shown in the news with some woman had all kinds of stuff underneath her eyelid embedded, essentially became part of the tarsal plate. So these do interact with our patients. And so you think it's more just long-term exposure, it's cumulative exposure in many cases that's ultimately causing damage?
Yes, undoubtedly the accumulation of mildly or poorly toxic, weakly toxic compound or irritants is very important. This is a very good example with the preservative. The preservative in eye drops is weakly allergenic because it's a small molecule, especially benzyl sodium chloride. So the rate of allergy, immediate allergy after a few days is very low, which makes apparently safe this compound, but it is an irritant. And allergologists well know that. Irritation is different from allergy. Irritation is due to accumulation, which means that, for example, the normal eye, normal ocular surface, young or rather young people receiving, for example, in glaucoma, 1 drop a day with a preservative will tolerate it very well because it will cause little allergic reaction or almost no allergic reaction, and once a day will not cause major modification of the eye. It is totally different if the patient has already a dry or MGD or rosacea or special sensitivity at the level of the ocular surface and progressively requires 1 drop a day, then 2 drops a day, then 3 drops a day. And in that case, the accumulation in time and accumulation during the day of many medication or several medication at least will interact with the ocular surface and will cause progressive inflammation, dryness, toxicity to the goblet cells, which is very important to consider both in dry in general and in toxicology in particular. So progressively there will be this accumulation. So it's a very good point. And again, the idea that the compound was started several years before or 1 year before and cannot be associated to what we are observing now, it's wrong. We should consider that even a compound that was initiated long time ago may be responsible for the problem.
Very interesting.
Chris, I can tell you as a father of an 11 and a 13-year-old daughters who are now, especially the 11-year-old actually, who's really getting into makeup and cosmetics. And of course, when they're starting, they tend to overdo it. So they cake on all this stuff. And I'm even seeing, we're talking about these long-term cumulative effects, which are very significant. But you also see very immediate effects too, because whether it's allergic, probably mostly allergic, but you can see her conjunctiva getting a little red and her eyelids getting a little puffy with all this caked on product of various types, whether it's eyeliner, mascara, powder, and probably things I've never heard of. And so I am certainly worried about it as a father too. I'm certainly trying to discourage excessive reliance on cosmetic and superficial things. But most importantly, also, if I know that cosmetics are inevitable for almost all women. So steering them towards safer cosmetics and looking at ingredients and trying to find products that are designed, for sensitivities and for patients with ocular surface disease and reducing any kind of long-term cumulative effects. And so, but I find it from a personal standpoint, very fascinating to be going through this for the first time and dealing with this and trying to steer my kids in the right direction.
You have her using the Eyes of the Story products?
Oh, 100%. Yeah. I am encouraging them to use Eyes Are the Story as much as possible, but they have a whole gamut of different things in their bathroom. And so while I'd like them to only use sort of safer products like Eyes Are the Story, I don't have a whole lot of control over what they put on their face every day.
And I'm not 100% familiar with Eyes Are the Story. What's different about it?
Well, I think Eyes Are the Story was designed from the ground up to be a safe cosmetic line in all of the long laundry list of toxic and, with a lack of true regulation, at least in the US, pretty much anything can go into these products. And so something like Eyes Are the Story, which eliminated all of those potentially long-term toxic adjuncts in the cosmetics, have been removed in favor of safer ingredients.
Yeah, that's great. I think they do adhere to European standards, which we know are at least a lot better than US standards. And let's take this home with a couple of topics. And Christophe, you've already hit on one of them sort of, but I wanted to start with systemic medications and Chris, maybe you can take us through this too. The two things I'd love to hear about: systemic medications. Of the top 100 that are prescribed, 22 may be causing dry eye, pretty big number, and just kind of reviewing that patient history and getting an understanding of what might be behind their dry eye. And then really getting into Christophe's area of expertise. I would love to hear more about your thoughts on BAK, for example, and glaucoma. So, Chris, what strikes you about the findings of the Iatrogenic committee and medications?
Well, I think the realm of glaucoma medications and the long-term burden of the drops, often multiple drops a day. Many of the drops, almost all the drops, do have some BAK in them of varying concentrations. And as we said earlier, that can add up over time and lead to dry eyes and ocular surface dysfunction, corneal staining, and just general ocular surface toxicity. But one of the interesting things in the subcommittee report was that it's not just BAK gets persecuted, of course, and preservatives in general, and rightfully so. But a lot of the glaucoma medications themselves, even without BAK, can potentially exacerbate dry eyes. The beta blockers and the prostaglandins, and there's a long list, a beautiful list in the TFOS DEWS2 report that with all of those sort of topical medications and the not just glaucoma medications, a whole NSAIDs we talked about. But I think that's something that doctors, that's a good point to make and Christophe, of course, you know a lot more about this than I do, but it's not just BAK and it's not just preservatives in topical medications that can lead to dry eyes.
So, Christophe, what are your takeaways from what did you learn in your subcommittee about systemic and topical, starting with systemic medications, for example?
Systemic medication may effectively play a role. You have a good example with antidepressants. And antidepressant is a very interesting topic because plenty of people take them. This induce dry, and dry favors depression because patients are suffering a lot. You have a very good vicious cycle. If the people feel depressed, they take pills against depression. If they take pills against depression, they feel more dry. Beside the joke, it's important to consider that effectively some patients are suffering a lot, and effectively interaction may occur with systemic medication. But effectively beta blockers, antihistamine may also cause dry. So to be aware of the role of the medication or aware of the iatrogenic compound is very important. It's absolutely right that BAK is an important compound, probably not alone once a day, but the accumulation over time when there are several drugs are important to consider. Other systemic medication may also play a role, and locally the active compound may also be involved in ocular surface disease. What I would say, if I I had a message to deliver, it would be what I call the subtractive strategy in the iatrogenic case. What does it mean? We, as physicians, are educated to, when we observe a problem, for example, a glaucoma patient developing dry or redness or MGD, we are educated to propose a new treatment. To add the treatment, this can be artificial tears, it can be anti-allergic medication, it can be lipid or thermal pulse therapy, not to give a commercial name, but we can propose a new treatment, a new intervention. Rather than that, yet to be aware of the iatrogenic role of some compounds is a way to try to develop the subtractive strategy. What does it mean? If we identify that probably this compound could cause an allergic reaction, or the preservative could be taken in high rates that can be toxic, or if we identify that an external medication may play a role, if possible, whenever possible, we should consider removing what could be, at least in part, maybe the only cause, but maybe not the only cause, but at least in part the cause of the problem. For example, in glaucoma, we can stop a medication suspect to be involved in the intolerance and propose laser trabeculoplasty. Maybe not always a surgery, but laser trabeculoplasty is a good way to decrease the pressure and to remove the medication instead of that. And in that case, just to finish with this point, if we just refer a glaucoma specialist who observe an involvement of the ocular surface, if the patient is referred to the cornea specialist, this can be a good option. But in that case, it will be very difficult for the cornea specialist to decide something about the glaucoma, to decide to do laser trabeculoplasty or to remove this compound rather than this one. So the is counter-effective, and sometimes considering that there is a problem and trying to stop, remove, replace what could be one of the cause would be much more effective.
And Chris, you brought up a good point about prostaglandin analogues, which essentially are causing inflammation on the surface of the eye. And what's the consensus? Is it more about the preservatives? Is it more about the PGA? What's the culprit?
I think it's probably mostly, it depends on the particular drop and the concentration of BAK and the number of times a day that they're using. But I think probably BAK in general is more toxic than just a prostaglandin analog by itself. But certainly the combination is significant. And just touching on what Christophe was just saying, similar to SLT, patients who are undergoing cataract surgery, who are glaucoma patients and on at least one drop or more, often these days we're recommending MIGS, micro and invasive glaucoma surgery, commonly in an effort to hopefully reduce that drop burden post cataract surgery. Of note, and also in the TFOS DEWS 2 subcommittee report, the iatrogenic report, on the list of systemic medications, and again, coming from this cataract surgical, what we touched on earlier with the ASCRS algorithm, knowing the effect of surgery on ocular surface and dry eyes. One thing I'm not sure I knew before this report was that the prostate medications like Flomax, tamsulosin, alfuzosin, finasteride, and others are also, and of course we as cataract surgeons are always looking for those because of floppy iris syndrome during intraoperatively. But also they're on the list too for dry eyes. So of course, talking about vicious circles and things leading to other things, not only does that do those drugs, the systemic drugs, cause problems with floppy iris, but now they also cause potentially worse than dry eyes afterwards as well. So it makes the pre-op conversation with patients a bit more challenging when you have to discuss all of those things.
And it sounds to me like there's a real opportunity to be communicating with their primary care physicians, the people prescribing the medications. And does there exist such a thing as a list of the worst offenders for antihypertensives or antidepressants? All these medications, are there I mean, certainly within antihypertensive medications, you've got your ACE inhibitors and diuretics and others. Is there such a thing as, well, if we've got a dry problem and all things being equal, we can put them onto this medication? Same for antidepressants. Is there such a thing as that?
I guess no. It remains anyway very difficult for the ophthalmologist, even discussing with the GP about the condition of the patient, to propose to change. For example, anti-hypertensive agent may, for example, participate to dry, but how to propose to remove this treatment and to propose another treatment. It's the same story about the corneal specialist who will be uncomfortable to propose specifically a new anti-glaucoma strategy. It's difficult for us. At least for me, I'm not comfortable. So, and just if I come back to the vicious cycle, one of the interests of this theory is the fact that in fact, as soon as the patient has entered the vicious cycle, in fact, it is dry in that case, is disconnected from the cause. And the good example is that even if antidepressant agents have participated to the development of dry, stopping antidepressant agent will not be able to relieve the patient. And this is a current observation. The patient stopped antidepressant, becomes even more depressed, and in fact is not relieved.
And, and is it true? I've always heard in Europe, SLT, physicians tend to go to SLT prior to medical therapy for glaucoma. Is that the case?
I know that effectively there are good papers showing that SLT first can be a good option to avoid or to delay the need for medication. We use SLT we've been using that for a very long period of time, almost 20 years. But it's not so usual to propose SLT first, unless the patient doesn't want to start medication because of the burden of the use of medication on the long term, or tolerance issues. So it's not so common to start with this strategy. We use it more as a complement to medication or to an alternative of medication if medication raise some problem.
Let me ask you both. If you were diagnosed with glaucoma tomorrow, early, mild stage, pressure's a little bit high, cornea a little bit thin, optic nerve doesn't look too bad, but you gotta lower your pressure, what would you choose?
You want me first?
Sure.
Yeah.
I can be extremely honest. I would start with preservative-free prostaglandin, because I know about the efficacy of once a day. I know that even if we have been discussing about the effect of the compound itself, effectively it may cause hyperemia. So hyperemia can be sometimes an issue. But I would start with this kind of treatment first, because I have a personal effect that I can share with the audience, because plenty of people have the same problem. In the past, I tried, because I had some migraine, to use beta blockers. And beta blockers made me feel very bad, with a very, very bad mood feeling, close to depression, not so much, but I was very bad. And some patients don't dare to talk about that with their ophthalmologist. And in fact, I would not use beta blocker for this reason. But anyway, I prescribe beta blockers as far as I don't identify specific problems. So I would start with PG unpreserved.
But and if you start feeling a little bit down, Christophe, you just give me a call and I'll try to bring you right back.
I would probably agree with that. Actually, my diplomatic answer would be, well, I'm not a glaucoma specialist, so I would defer whatever my glaucoma specialist recommended for me to do as first step. I would just follow his or her recommendation. The PGA, I think, is perfectly reasonable. I've already got dark brown eyes already, so I wouldn't worry about pigmentation. And of course, my eyelashes could always be a little bit longer, so that would be nice too. But if they said, hey, SLT would work perfectly for you, you may not need drops ever, safe and easy. In my hands, I have no complications, and I would go with that too. But we should, we were already at the 1 hour mark. So maybe as a close to finishing, we were talking about the psychology of dry eyes and some of the systemic medications to treat it. In our year of 2020, the crazy times that we live in. In fact, I just saw on the news just yesterday a story about how people are in general drinking more alcohol. And one of the iatrogenic sources of dry eyes in the TFOS DEWS II report, well, there was some mention of alcohol. And so, Christophe, as the expert, what does alcohol do to dry eyes in the ocular surface?
I was really interested in that question, and I tried to get an answer. What I got as information was that high consumption of alcohol may cause dry, clearly, but what I could say, standard use or mild consumption of wine or mild alcohol seems to be not to really influence the dryness. So, like many things, excess is too much, and mild condition, balanced condition, seems to be quite neutral.
Very good. Well, I sincerely appreciate your time. I do hope we get to meet for coffee someday. My med school daughter, upon her graduation, I was going to take her to Paris for a week, and that was part of the trip, was visiting, having a coffee with Christophe. And I hope someday we get to actually do that. I really appreciate your insights and your time, and your body of work is very impressive. It's something that gets cited and quoted in my lectures that I do around the country all the time. So thank you again. And Christar, as always, love hearing your insights and everything as well.
We will be more than happy to have our American friends and American colleagues coming back to France and coming back to Paris, and to welcome them and to be face-to-face to have such discussions. So I do hope it will be soon the case, maybe with the vaccination.
We like to always just kind of finish with, give me, I'll put you on the spot. Give me 3 takeaways. What should practitioners do based on your findings from Iatrogenic? Can you kind of sum up what should practitioners be thinking about in their practice based on the findings of your report?
I would say one message is not to miss the importance of ocular surface in patients who are not referred for that, or we have no intervention specifically for that. For example, before refractive surgery, before any kind of surgery, before or during the course of glaucoma treatment. So consider that ocular surface disease at some moment may become a major problem. For example, a glaucoma patient developing progressively intolerance and high rate of ocular surface disease and undergoing glaucoma surgery will not work properly. It will be a failure or high risk of failure. So consider ocular surface is important to in all your intervention, and not just considering that a stinging eye has no matter to or nothing to deal with glaucoma. Message would be where that subtracting what could be the iatrogenic cause is much more effective than trying to add something to compensate for something that caused something else. And last point, in the most severe cases, the disease becomes autonomous, a self-stimulated disease, the vicious cycle. And in that case, the cause seems to be disconnected from the consequences. So it becomes really a disease, really difficult to manage. And it's very quick to enter the vicious cycle. It may take very long to get out.
Very good. Thank you again. And especially during this pandemic, we didn't even touch on digital device use. And we know that's a big deal too. So perhaps another time. Well, everybody, thank you for listening and watching. Next, Chris and I will be covering diagnostic methodology on our next episode. Have a great day, you guys. Great to talk to you today.
Thank you very much.
Thanks for listening. Join us for our next episode soon. Find us online at www.ocularsurfaceacademy.com, all major podcast platforms, and YouTube.
Lacrimetics, providing proven dry eye disease treatment options since 1984. Contact us now.